Yeah, thank you very much for the introduction, and thank you for inviting me to Edinburgh. So I really love Scotland, and I really love this town. Thank you very much. So that's it. If you're wondering about my accent, I can tell you I was born in Germany and I've been living in Norway, so you might find it a bit hard. And as we're talking about palliative care, most people are used to suffering and coping, so I hope you can cope with the accent. What I'm going to talk about today is last aid and the last aid course, which was basically an idea I got in my time. I was taking a master in palliative care at the University of Klagenfurt, and it was the current concept was established with the help of the Norwegian Society of Palliative Care and the Danish Society of Palliative Care and people from Northern Germany, from Schleswig-Holstein. So it's a northern project. Today's menu, I'm talking a bit about the background of the project, my personal background, and the birth of the idea. Last but not least, about the implementation and our experiences so far. And I will provide you with an insight into the future perspective. The background of the project is pretty obvious. We have heard about it already today in other lectures. We have aging populations in most countries. So there are coming more old people, and there are coming more people in need of palliative care. So the demographic change will increase the number of people in need for palliative care. If we look at most Western countries, many people do want to die at home. I have some numbers for Germany in this presentation, which is about 66%. And you may well know from the literature, it's not 66% who manage to die at home, it's about 20%, or there's a big difference. So we do know there is a need for palliative care at home, and this need is going to increase. Therefore, I think the public needs a basic knowledge about palliative care, and as we know, it is both knowledge and attitude which is the foundation of palliative care and compassionate communities. To understand the last aid concept, I think it might be helpful to know something about my biography. So I started at the age of 14 as a volunteer in the St. John's Ambulance Service in Germany, and I've been a paramedic by the age of 18, and I was a first aid instructor at the age of 17, so I have more than 30 years experience in emergency medical service and teaching first aid. And I wrote my first book on first aid at the age of 24. So you could say I'm really first aid person. Later on, I became obviously a specialist in anesthesiology and emergency medicine, but I recognized there was also need for pain medicine and became a pain specialist and was so consultant for the palliative care team, and that led to a specialization in palliative medicine. Yeah, and I'm just now appointed as a clinical associate professor in palliative care at the University of Southern Denmark. Where lies Southern Denmark? So you can see it on the map. It's in red. This is Southern Denmark as a part of Denmark. It lies close to the German border. And I'm the head of a palliative care team who serves a region of about 4,000 square kilometers with 250,000 inhabitants. So we drive a lot. Yeah, this is a presentation for those who are interested, which we had on the International Palliative Care Network conference about the project. And how was the idea of last aid born? It started with the master degree in palliative care at the University Klagenfurt and Vienna. I was actually working on a project which was about how can we teach palliative care for old and demented people. And it was somehow, so to say, it was a project in the project that the last aid course started, because I thought, if we are going to teach people working in nursing homes and teaching healthcare professionals, why shouldn't we teach the public? And so the first time the idea was mentioned was in 2008 in this master thesis, and it became a book in German, unfortunately, in 2010. And it has been presented on a number of congresses. The first presentation in English I can remember was in 2009 on the Congress of the European Association of Palliative Care in Vienna, where I was standing beside the poster and nobody asked me something about last aid, so I was somehow disappointed then, but that has changed. This is something which I wrote in the book. There you can read a short last aid course implemented in the public school education and offered for all interested people could be a part of the public knowledge approach to bring palliative care into the society. And already then I have given some suggestions for what to include in the last aid course. The most important thing, we have heard it before also in another lecture, dying is a normal part of human life. I think we have to remember society, we have to remember people that is true. And it's of course, if you're thinking first aid and last aid, it's of course about problems around dying, troublesome symptoms, and things we can do at the end of life. But it's also about, that's not just medical treatment, there are also non-medical options, and it's about the question of fluid and nutrition at the end of life, a question that arises very frequently and that we have to deal with. So it's good to prepare the relatives and the public for that. And last but not least, after the death, there's also bereavement and grief. So that's also part of the course. With my history from emergency medicine, this question was obvious for me. I thought, why can't we learn from emergency medicine? Because they have taught the public for many years. And now I have presented a short video which inspired me. It's a bit old, but I think it's worth it. Oops. Yeah, I think that was enough from the video. It's pretty old, but I think it's pretty interesting because you see two things. You see, it's not a specialized service, but it's a specialized service and people from the community. And I think this is the same in palliative care. So what we have done in the last years, I think, is we have started to build specialist palliative care teams, but I think, where's the public? So, and you see that the chance to survive a heart attack does just work if you have both. So I think palliative care can learn from emergency care, and I think it's really important that they empower the public. I don't know how it is in Scotland, but I can tell you I've been working as a doctor in both Germany and in Norway and in Denmark, and most people think a good death can only be if you have a palliative care team at your side. And that's not true. We all know that, but we have to empower the people. So you could say, probably it's back to the roots, back to the hospice movement. Include the people. And if we try to characterize what is first aid and what is last aid, one could say first aid is more about measures to save the life of a victim or to avoid further health problems. And if we try to define what is last aid, you could say it's about measures to care and to comfort people with life-limiting diseases in order to enhance quality of life. So it's all about quality of life, yeah? And quality of life is more important than to prolong life. That's the basics. Oops. Yeah. Interestingly, when I first presented the Red Cross and other organizations for the idea of last aid, they answered me, no, we do first aid, but we have nothing in common. We don't have last aid. We don't want to provide last aid. And when I moved from Norway to Denmark, I read my first book in Danish, and I found this one here. It's about Henri Dunant, the founder of the Red Cross, who was in the Battle of Solferino. And there you can read, Dunant tried to help with whatever he could. he kneeled beside wounded men who begged him to stay with them to their last breath, so that they would not die alone. And this is very interesting, because now I use this when I talk to the Red Cross or to St. John's or whatever, and they believe me. So it's really interesting how that can work, but Henri Dunant has done it. So it's not, you cannot say, okay, this is Georg Bollig who came up with the idea of last aid. You can say it was already Henri Dunant who provided last aid at the Battle of Solferino just before the Red Cross was founded. And if we look back in history, last aid maybe has been provided for many thousand years. It probably was not called last aid then. When I had to defend my master thesis at the University of Klagenfurt, I was asked, isn't the main difference between first aid and last aid that first aid is only about skills and last aid is only about attitude? I don't know what you think, but I responded and said, if you are going to resuscitate a man who has vomited, it's about attitude, not only skills. So I think it's both first aid and last aid is mostly about attitude. And that I can tell you many about, because I've been driving ambulances for many years and I've been an emergency doctor for many years. So it's about attitude, mostly, a bit skills. And what you can see, if you teach children in the kindergarten and teach them first aid, I've been looking scientifically into this, because I've been in the kindergarten of my children and taught them first aid. So you can see it's also about attitude. So, sorry for this German slide, but it's, I think you get the message. One could say attitude is the foundation of palliative care. If you're a hospice volunteer or if you're a doctor, attitude is the basic. And if we now go back to emergency medicine and look into the chain of survival, this is a Norwegian style here. So you see, it's always important that people work together. That was what we have seen in Seattle. That's why they have succeeded in Seattle. They work together. There are lay people who recognize there is a problem and start resuscitation, call for help, and then is the specialist who comes to help, and then the patient is brought to the hospital. That is what works. And I thought, why don't we use that in palliative care too? Therefore, I have said we need a chain of palliative care, and we do need a public knowledge approach. So we need to transfer basic knowledge about palliative care into the public. Probably you could say back into the public, because 100 years ago it was normal to have dying people at home. And the most important is, the aim is to ensure the best quality of life possible. If you look at it, it's really important to remember, a chain is only as strong as its weakest part. So what do? We just have a specialist team. We also need the people out in the streets and the people in the homes. So it's really important, if a patient himself or relatives recognize there is a need for palliative care, it should be enough that they contact probably a district nurse or a general practitioner or a chaplain or a social worker to start palliative care. The problem is to find out what are the patient's needs. This is a bit more complicated than in the emergency medical service, that's right. Well, I think it could be really okay if we had a palliative care number, so which is the same all over Europe. So you just dial the palliative care number so you get help. That could be a future idea. And then comes the general palliative care part, which should be provided of all people working in palliative care, all general practitioners, all nurses, chaplains, everybody. And if that is not enough, we should be able to contact a specialized palliative care team, so we should have specialists going out to help there in the homes, or probably via telemedicine or something. And just if that is not enough, then we do need hospices or palliative care units in hospitals, I guess. And remember, most people want to die at home. So, there are some more questions. How can we educate the public, and is it really possible to change people's attitude and behavior? These are the main questions to address. I think there are three components of palliative care competence. This is attitude, we have talked about that. It's also knowledge, and there are some skills to learn. Frank Ferris from San Diego reminds us, education targeted to improve knowledge and attitudes does not change behavior. So knowledge is not enough. A very interesting approach from Japan. They used a 1-hour educational lecture given by a physician with a big audience about end-of-life matters, and they have published a paper here in Palliative Medicine in 2008, and they say they could change beliefs regarding feasibility of home care, preferences for life-prolonging treatment, and attitudes toward end-of-life care. I must say, I doubt it, but probably I'm wrong. Ferris has also provided us with this picture here about sequential outcomes of education. So when we are going to educate the public, it's really important to remember that. It starts with attitudes, and you need knowledge, you need skills, but then there has to be behavior. And that is what they did in Seattle. They changed behavior. This is the town in the world where it's the best place to have a heart attack. But this is just behavior. The public has worked on it. And that is what we need to change. And if we can change the behavior of some people, that will lead to patients or families who experience that, and this will change the experience of the whole society. So, it's really important to focus on what they need to know in the shortest time possible. Singer has said one time, the challenge is to develop systematic and comprehensive information on the quality of end-of-life care at the population level. That is what we tried to address with the public knowledge approach, which includes the chain of palliative care as a model of palliative care provision in the community, and the last 8 courses for everybody, including school pupils and the whole society. And that's the aim is, as I said before, that knowledge becomes public knowledge. And I've designed a 6-step approach where you can see it starts with an introductory course for all, also school pupils, and I think we do need palliative care education throughout the system. So we should educate all general practitioners, all nurses, all chaplains, all social workers. And this is depending on how much are you involved in palliative care. And then we have the step 4 to 6 is more for the people who are more specialized. In Germany, we have a specialization which is about 160 hours education for most practitioners working in palliative care. And I think we do have to have a specialization in palliative medicine. It's not everywhere so as it is in the UK. So in Denmark, we have a sub-specialization. In Germany, we have a sub-specialization. It's not a specialty yet. And step 6 is research, doing a master or doing a PhD in palliative care in order to provide that. So, the last 8 course. Now I would like to show the video if possible. Bill. Yeah. Great. This is a video which was broadcasted in Germany. They accompanied me with a patient and then teaching the last 8 course. So it's in German, and I'm going to focus on some highlights and try to translate it for you. The problem is always that television wants to see patients. I said, no, I don't want to show my patients on TV. But I asked the patient, and she said, no, I volunteer. I want to be with you gee, that's great. So, and that's this lady here. I was saying there in the interview that I think the chance to be involved for care of the dying is much higher than the chance to be involved in a resuscitation situation. So, and therefore I think if we are preparing each other for first aid situations, we should prepare each other also for last aid situations, because they are really more frequent. So why don't we? So what's the last aid course all about? We had an international group from Denmark, Norway and Germany, and we used the concept which we previously had established for the Red Cross in Austria. We had a cooperation with them, and they told us, okay, we can try a last aid course, but they want to have 16 hours of teaching, because that's the usual amount of teaching you do in Germany and in Austria for a first aid course. But interestingly, they said, no, we're not interested. We don't do it in practice. They were a bit afraid. And then we tried to get back to the original idea, and we formed a basic last aid course with 4 modules, each module about 45 minutes. And the first one is about care at the end of life, with addressing that death is normal. The second one is mostly about advanced care planning and decision making, preparing. The third one is about symptom management at the end of life. And the fourth is about cultural aspects of death, bereavement, and grief. Practical aspects of the session is we are usually doing it in an afternoon or an evening, and we use 1.5 hours with a break of 30 minutes and 1.5 hours again. That does work. Usually it is given by a team of 2 certified instructors. We recommend that the course shall have about 8 to 15 participants. We have had courses with more than 30 participants, but the problem is then people don't interact, so they are afraid to tell what they mean. The methods used is mostly lectures, group discussions, and mini groups, and they do practice. As you saw in the video, they do practice in oral care, so they try how it is to give oral care to another person. And places we used are both hospital, hospices, schools, and all places for education, so to say. We use 2 instructors because we think this visualizes teamwork in palliative care. And in the beginning, we were really afraid. There were some people saying, okay, if you address death and dying in the public, people might get a post-traumatic stress disorder or something like that. So there might be complications. And we thought, okay, we have another one to back up. And I can tell you, we have never seen problems. That's it. People start to cry a bit. That happens, but it's not dangerous. So it works. One important thing is, if you are instructor for this course, the people come into the breaks and after the course with many questions to you. So it's really you have to prepare yourself, and this is also another argument to have 2 instructors, because it's really intense being an instructor on the course. Yeah, the topics are. For the first module, you can say it's mostly about to care and to accompany. We talk about the dying process. We talk about which possibilities for support are existing, types of palliative care teams, and we talk about what is hospice philosophy, what is palliative care. And it has also a philosophical part. So at the end of each module, we have some kind of philosophical question. So what will be important for me when I have to die? And that is more that people can take this. We usually say this is a take-home lecture, so you can do it at home. You can think about it at home or discuss with your relatives. Part 2 is about advanced care planning. It's about to make decisions. We talk about decisions which are mostly medical, and about decisions which are mostly personal or ethical. And we talk about how can we reach good decisions. And then we talk about the possibilities for a living will, for example, or advanced care planning. Part 3 is the part which is most interesting for most participants, because it's more this first aid, so what can I do in the actual situation? So it's about how can we alleviate suffering. It's again, when does the dying process start? It's about which options do we have to handle pain, and it's also about the role of eating and drinking at the end of life. It's again, it's a mixture of education and a sort of philosophical discussion, and it's reflecting with the people. This is the really challenge for the instructors. The 4th module is about to say farewell. It's about regulations, about death certificate, for example. It's about the funeral. It's about rituals. Are there supporting rituals for us? Do we know supporting rituals, for example? Because in the modern societies, it's so the Christian belief is not as important as it has been. Here you can see a picture from one of the first courses. This was the first course in Schleswig in Germany, and you see the 2 women, they thought it was fun to do that oral care, to learn and to try. Let's try some coffee, let's try some orange juice. So how is this? And many people say afterwards, I think I'm going to change my living will, and I want oral care with orange juice or with champagne, for instance. So it's really experiencing. So that's the most important part. And as you see, the first course was one of my dear colleagues, Annette Esther from Norway, who did it in Norway in November 2014. So at present, in Germany, we have already educated more than 1,800 people. We have an evaluation questionnaire which we use, and we have about 88% of the people who answer the questionnaire. So we are going to collect some data so we can publish. Most participants think this course is really good, and they would recommend it to others. So they say, for example, if I only had known that before, it would have helped me when my aunt died. That was the girl who said it in the video. And I appreciate the natural way to deal with the topics death and dying. Many say also lively and easy, although the topic is complicated. So people really appreciate to talk about death and dying. These were the first publications. The first one was in Norwegian, where it's called Siste Gelbskurs. And yeah, so we have different languages. The other one was in German. And here we had the experience from Germany with pilot courses. We did a scientific paper. We had 55 participants, 45 women, so we have some problems with men, so men are not attending the courses, unfortunately. The age was between 21 and 82 years. 95% filled out the questionnaire. And this is from the German publication. And you can see it was one was the best, and most people think that module 3, to alleviate symptoms, was the best part of the course. And we've discussed that in deep, but we think now it's probably like this, that many people are in a situation where they want to plan for the end of life. So then number 2 is the most important, because it's about planning. Other people are in grief, so probably module 4 is the most important. That's what we think, at least. Yeah, then in 2015 we have got some prize. We did get a prize for that from the German Association for Palliative Care. This is my colleague and social worker Nadine Kugler, who was with us, and we were one of the best social activities in Germany in the year 2015. And I think this is a really nice picture of Angela Merkel, because she's like all of us. She doesn't want to look at the end of life, she looks at the beginning. So that's what we all do. Then we have had some presentations in Montreal last year, and we have had a symposium in Germany. So you could say our experiences are that visiting the last aid course leads to that one talks about these topics, also in the families. And so we have really heard from people who visited the course that they came back and said, yeah, we talked about that in the family. And we have experiences, I personally have had experiences from former course participants who called me in the hospital and said, Dr. Bollig, I need your help because I have cancer and I don't want to die alone at home. What can we do about it? So it's really, the course does work. The course does take the discussion about death and dying and the discussion about palliative care back into the society. So that really, really works. I think it's mostly about, we do give education, but we also provide an open space and we encourage participation of the people who attend the course. And this is what most people also write on the evaluation scheme, that they have a space where they can write comments. And many do write the open discussions, the communication and the discussions. And I think you can learn about that. Talking about death and dying does not hurt. That sounds a bit strange probably, but I think that is the take-home message, because they do it in a group and they see, okay, I can talk about that to other people. Why can't I talk about that in my family? And they take it home. Yeah, I think we can. Yeah, we have already written a handbook for participants, which is available in German since last year. We are working on a version for Switzerland and Denmark, and we're thinking about an English version too. In order to protect the system, it has been registered as a trademark. And this leads to the future perspective of the project. As I said, we have 1,800 people have taken part in the courses. In Germany, we have already almost 500 instructors. These are some numbers from last month that we had in Germany 400, in Denmark more than 60, in Norway we have crossed the 100 in Norway also. And we have some in Austria, we have some in Switzerland and one in Sweden. So we are expanding. In the future we plan to have an international working group which meets every other year in order to have a core curriculum on last aid, which so can be adapted to local needs in the different countries. Because living will is obviously different in Scotland than it is in Germany or in Denmark, and the organization of palliative care teams is also different. So this has to be taken into account. Yeah, we had also a symposium where we had instructors with experience to do the course, and we have done some focus group interviews. And they say it's fun to teach. They say also every course is different. So it's really complicated to be an instructor, one could say. It's challenging, but it's worth it because it's really fun. If you teach these courses, no two courses are the same because there are different people attending the course, they have different questions. So therefore it's really important that there are two instructors and one has to have a medical background, at least as a doctor or as a nurse in palliative care. So that's what we are working on in the future, is that we have a last aid international working group and that we have last aid in different countries with different names. In some it's Sistehjelp in Norway and it's Sistehjelp litt annet. A bit different in Denmark. Yeah. We'd see. One major challenge is the adapting to the different countries' needs. And I think I have to speed up slightly. One thing which is important to us also, we would like to follow this up with scientific research. So we are doing a short questionnaire for the course participants, and as I said, we are aiming to have 2,000 to get a publication. And in the future, we are also aiming at a follow-up interview probably of the course participants to see has that led to other discussions or other things that happened. So my vision is that public education in palliative care using last aid course or others will become as normal as first aid education. And I think it could use, the 6-step model could be used in implementation. And last but not least, palliative care should be available for all in need and without geographical differences. This might be also challenging in Scotland, I guess. So I would say, in my eyes, we could have an approach where we need compassionate communities. And I think the last aid course is kind of a basic knowledge for the compassionate communities. And I think I've discussed that with people from Ireland, from Limerick, who have a compassionate community approach and using death cafes. I think it could be much better to combine probably a last aid course approach and death cafes. So you have a more open approach and you have a more structured approach for people, so that you address both. Last but not least, I think in regions as southern Denmark or probably also Scotland, telemedicine could be a part of that. So last aid could be a kind of basic knowledge and basic education and reflection for the people about palliative care, and you can then support them to care for their relatives at home using telemedicine. I think that is the future, from my perspective at least. Yeah, that's it, I guess. So I think the future efforts should try to combine last aid courses, telemedicine, and compassionate communities. Many people have supported the project. There are some publications. There is a publication in English on the internet from the Austrian Palliative Care Journal, which can be downloaded from the internet. Our homepage is unfortunately only in German so far, but we're working on it. So we hopefully get an English one within this year. Yeah, these things I said. We are also working on an international congress next year. We see how far we can reach. And remember, life is short and this is no diesel. Thank you. Yes, of course.
Thank you, George. I'm Kenny Steele from Highland Hospice. We heard about last aid, it was just a couple of months ago, and it rang so many bells for me. It's interesting you talk about the Death Cafe and some of the other promotional work that we've been doing around Good Life, Good Death, Good Grief, which is great stuff, but it's quite, it appeals almost to the enthusiast, whereas I think the practicality of last aid is, I think the relationship with first aid is brilliant. I mean, and I think, I mean, I've never needed first aid in any organisation I've ever worked in, and we've always had several first aiders, but I've had every organisation I've worked in, I've had colleagues, I've had relatives, that I've had experience with death, dying, bereavement, and struggled with it. So why on earth don't we put this into society, into workplace? But my question really was about the scalability, where I think it's great that you're saying we need a doctor or a nurse in palliative care to run the course. Which
that's what we found out at least.
I can understand just now, but then if you really want to scale this up, and I think it should be ambitious to try and get this into every workplace, we'll run out of doctors and nurses, and do we actually need to, just like first aid training is delivered, it's not by a emergency medical practitioner, it's by somebody that's trained in it.
Yeah, two things. It's in Seattle, it is a paramedic who does the training, just to say that. I think you're really right, Kenny. I support that. But I think this is the first step. And I think in the first step, we have to secure that the courses are good and that people do like the courses. And many people, that is our experience, come with questions related to medical things. And there it's best that you at least have a nurse or a doctor with. So although we say there are other people invited, and we do have some hospice volunteers who teach the course, no problem. We do have teachers who teach the course. We do have undertakers who teach the course. So it's a bit person related, you must say. And I would agree with you if we want to have this large scale. So I think the next step is when we have reached that in the public people know there is a last aid course, we probably should go one step further and educate people who educate the public. Even you could call that for a form of peer teaching, I would say. But that's the next step. So I think it's probably we're talking about 2025 or something. There was a question.
Is that right? Thank you, George. That was fascinating, and a bit like Kenny was saying, rang a lot of bells for me. I work as a lecturer in adult nursing, and I'm just wondering if that model could be used in teaching student nurses in the classroom.
Yes, of course, you can do that. There are many people who use that also in professional settings, but I would say our personal experience is that a mixed group is best, because you want to teach the public, you want to bring this into the public, and we have run some course. The first course was actually I did with the church in Schleswig, and there was many elderly people attending the course, and some days after, this was in the newspaper, so my colleagues came up to me, why haven't we heard about it? We want to attend the course too, so we had a course for healthcare professionals, but I think the course aims, first of all, to normal people. So it's okay that doctors participate and healthcare professionals participate, but I think it's much better if you reflect with others who are not from a medical profession. So you can use it, but it has certain limitations. There was another question.
Nuta again from St Columba's Hospice. How do you approach organisations to host these events? Because I think one of the things that I gather is that it's not just in healthcare settings or hospices, but actually community centres and churches. How do you approach people to say this is what we'd like to do?
Yeah, this is usually we educate instructors, and then the instructors themselves approach different settings. It's different in the different countries. So often it's connected to churches, because then they already have an association who meets there or something. We have in Northern Germany, we have farmers' wife associations, I would say, is it called in Scottish probably. They are really active and invite people. So we have sometimes it's a football team, or it's very different locations where we do that, and we have a huge experience in Germany with people taking evening classes. So it's very often, so in the same amount you can learn to cook Chinese, or you can learn Italian, or you can take a last aid course. So we use different settings, and we use also different methods of approaching people. It's in Hamburg, there are a lot of hospice services, so home hospice services, who use that actually to advertise for volunteers. So we have an experience that people who attend the course are interested in an education as a volunteer for a hospital service, for a hospice service. So just to try whatever one can. Also, there have been people in Germany suggesting we should probably have it in a bar, but that has not been done yet. Yeah, probably that would work though. Yeah.
Scott Murray, a GP from Edinburgh. This sounds tremendous, really exciting. Have you any information about the volunteers that you train? The types of people that they support? Is it the relatives or neighbours? Or what's their scope or their reach that you suggest? Thanks.
Yeah, thank you for your question. That's the main thing which is missing that we have to address. We started with a relative simple evaluation where we just asked the people what we thought about the course, but we didn't ask about what was the background or what was the motivation to come to the course. That would be a thing to address in further research. We haven't done that yet.
And the number of people they reach, have you got information about that?
No, not yet. But as I said, you can see, if you see at the timetable, the first course in Germany has been in January 2015, so it's just exploding, you can say. So that's why we're looking for international collaboration, so that we also can collaborate in designing research and doing research on the project. So.
Yeah, Mark from the partnership. I was just interested to know, the course, as I understand it, is 3 hours. And I'm interested to know how difficult it is to get agreement about what is the most important stuff to cover in quite a short time.
Yeah, that is obviously the biggest challenge. No, that's why we do it as a first aid course. So we say these are the themes, and there are some main themes which have to be addressed, and there are minor themes which can vary from group to group. So this is the real challenge for the instructors, and therefore it has been really a challenge for us to say who can be an instructor. So that was really, really difficult. And therefore we designed a type of instructor course where people get some slides from the last aid course and have to present it on the course. And then we can see how do they the teaching. So, and I can say we have in Germany, we have 500 instructors nearly, and I think there are 4 instructors who didn't get the certificate. So most people do it, and it works. I do know, so I have some information about courses where people have used too much time, and there have usually been complaints after that. Because it's really, I think if you are a citizen who wants to visit a last aid course, it has to be clear that the timeline is 3 hours and then you can go home. And we have had people who said, that was really fine, 3 hours, and that is enough for my whole life. But on the other hand, they wanted to participate. It's the same with first aid. There are people who do a CPR class, never attend again. So, but they have got some knowledge.
Mine is really more a comment than a question, but we've recently produced a framework, NES, for the whole of the workforce in health and social care, and it was very interesting when you put your content up. I would say that I could map that to informed level. Sure. So the knowledge and skills and behaviours we've put in that framework at informed level, which is for a cook in a care home, a gardener in a hospital, a receptionist in a primary healthcare team. It maps beautifully. So there you go. There's a promotion for the framework, but you know, very similar content in that. So thank you.
Yeah, thank you for the comment. But I have to admit one thing. There was one thing that we have missed actually in the course that we have recognized and that we have heard from the participants, and this is how can we talk with children about death and dying. This was a thing that we truly have missed, and I must say for me it is so natural to talk with children about death and dying that I just have forgotten it. So that will be an adaptation in the next version. But otherwise the people have the chance also to comment on what they would want on the course. And there are not many comments, I can say. So the people think that's okay as it is.
Sorry, I'm just so enthusiastic about this. I was just to say that we've taken the opportunity when George is over, we're dragging George up to Highland tomorrow to do a piece on last aid up with us, and we're very determined to pilot the course. We've got at least one workplace interested, a couple of community settings, and also hopefully the NHS. So we certainly hope, if George is willing, to get some trainers trained up in Highland to pilot the course, hopefully later this year if we can. Because I think it's got huge potential. So certainly anyone that's interested perhaps might be able to combine if people want to come up to Highland maybe later in the year if people are interested.
Yeah, we talk about that. So as I said before, I love Scotland, so that might be no problem.
Can I just
Thank you all.